up and the volume decreases, your volume increases and your pressure decreases and air rushes in. On exhalation, the exact opposite happens. The volume decreases, the pressure increases. Now the pressure inside your lungs is greater than that pressure outside of your body. That atmospheric pressure and your pressure air rushes out. That in all of itself is inhalation and exhalation. It's all basic physics. Now, inspiratory muscles. If your muscles did not work, you would not be able to breathe. How that comes into play is, anybody heard of muscular dystrophy? Jerry's kids, you might have, for those of us who are older, muscular dystrophy. These are kids that over time their muscles lose their ability to contract. And that is ultimately what used to kill these kids. They would not be able to breathe. Their muscles would quit working. And so that's exactly what happened. So you have these muscles, the external intercostal muscles, the muscles that are surrounding your rib cage. This is what helps pull your rib cage up and allows your volume and your pleural space to increase and your pressure to decrease inside. And those nerves are supplied by your intercostal nerves. And your diaphragm is receiving that innervation from your phrenic nerve. I'm sure at some point in everybody's life you've been hit in your diaphragm, or you've had that hit in your phrenic nerve, and it stunned it and you can't take a breath for a little bit. It's got another name that people call it, but your solar plexus, that's what people like to call it. You get hit in your solar plexus. What you're actually getting hit is in your diaphragm, in that phrenic nerve, and it stuns your diaphragm and it can't contract. And you can't breathe because of that until that eases up. Doesn't feel very good. Yeah. Yeah.
Oh, I was gonna say, can't you hit the spleen and knock somebody out?
I mean, if you hit anybody hard enough in the stomach, you can. But if you hit somebody's spleen, you can cause it to rupture, and that can cause a hemorrhage. You can actually kill them that way.
Mm.
So the diaphragm receives innervation from the phrenic nerve. So the phrenic nerve, is that part of your parasympathetic or sympathetic nervous system? Anybody know? Your phrenic nerve is basically part of your parasympathetic nervous system. So read this question carefully. Yeah. This is a little bit of a trick question. The physical process of pulmonary ventilation would be disrupted directly by someone holding their breath. What would happen if you held your breath for a certain amount of time? What would happen?
You faint.
Huh?
You faint.
You'd pass out. And then what would immediately happen?
You start breathing.
You start breathing again. Your brain goes, oh, I can do this. So when your 5-year-old starts holding their breath because they're so mad because they didn't get to watch their Bluey, or they didn't get to eat the rest of their, crap cereal or whatever, and they're holding their breath because 5-year-olds are wont to do that, let them go. When they wake up, they'll be fine because they'll wake up. So yes, the physical process of pulmonary ventilation would be disrupted by someone holding their breath. So muscle movement during inspiration and expiration. Again, this is telling you what we've already gone over kind of multiple times, but I really want y'all to get it. Inhalation, diaphragm drops down, rib cage pulls up and out, and the greater expanse you have, the more volume you create, the more your pressure drops and the more air can come in your lungs. That's why if right now everybody takes this really big deep breath, well, I want you to do this actually. I want everybody to take a big deep breath. I want you to sit up straight. I know you think I'm weird. I don't care. And then I want you to take a big deep breath. You just see how high your rib cage actually rises. That isn't it. The deeper your breath you take, the higher your rib cage rises, because the more air you're actually able to get into your chest. right? So, and that's a volume thing. When you're taking these little weeny little breaths, your rib cage doesn't have to rise that much. It's your chest doesn't have to rise and fall. It's a very, very calm, passive breathing. It's called a tidal volume, actually. So, but every now and then, all throughout the day, y'all are taking big, deep breaths. You'll take a big cleansing, like pop-up breath, right? So, for inhalation, for normal breathing, you will use your external intercostal muscles and your diaphragm. That's what you're using for normal, like at-rest breathing. For normal at-rest exhalation, it's all passive. Everything just relaxes. Your diaphragm relaxes, and your external intercostals relax, and your volume decreases. Here, your volume increases, your pressure decreases, and air rushes in. Here, your volume decreases, the pressure increases, and air rushes out. Active process, passive process. So this is Boyle's law. I'm going to draw it for you too. They're kind of saying it there. So if you think of molecules in the air, and they have lots of room to move, right? So you've got lots of volume, low pressure. You take those same molecules and you squeeze the volume in. Now these molecules are bumping into each other. Now you've got high pressure under lower volume, right? So Boyle's law is basically, as volume increases, pressure decreases. It's the exact same thing that's happening in the lungs. As you increase the lung volume, the pressure decreases and air is able to rush in. But this is a whole law. This is a principle of physics. This is Boyle's law. You absolutely need to know this. Absolutely have to know this law. It's inversely proportional. As volume increases, pressure decreases. As volume decreases, pressure increases. It's inversely proportional. And it makes really good sense. The pressure here is lower than the pressure here. These things are beating all over each other, so the pressure here is much higher than the pressure here. The volume is lower, the pressure is higher. The volume is higher and the pressure is lower. Absolutely need to know that. So we're going to have, in lab, we're going to see, tonight we're going to start doing it. We'll have some respiratory stuff to do. There is a bell with a rubber flap on the bottom of it, and we'll show you how the lungs kind of work. If you see it, it kind of makes more sense, so we'll talk about it when we get in there. But the process of ventilation, again, as the ribs move up and the diaphragm flattens out, you are creating more volume. As you create more volume, what happens to the pressure? Goes down. So now the pressure in your lungs is lower than the atmospheric pressure, and air rushes in, right? Now, as your diaphragm relaxes and your intercostals relax, now the pressure snaps back, now the volume snaps back, and the pressure does what? Increases, and now air is going to do what? Rush out, right? Y'all got that. So it's an easy answer. But we're breathing in what? Oxygen and breathing out.
CO2.
Everything that we've done in the alveoli, and we're going to talk about that more. So, we've seen this flow equation before, right? Where did we see that? Where did we see that before? Where? Blood, yeah, in the vessels. Delta P over R. So change in pressure over resistance. Same thing is happening in the lungs. Because we can vasoconstrict and vasodilate, but we can bronchiorestrict and bronchiodilate, right? So we have the same problem. We can have changes in pressure, and we can have changes in resistance. It can have change in air pressure. We can have change in resistance. Those bronchioles can restrict on us. So let's talk about all the ways we can change the resistance here. You can have a pneumonia, and those alveoli can fill up with fluid because of an infection. That's definitely going to change your resistance. You can have a history of smoking and you've got, your lungs are all stiff. That's going to change your resistance. So there's all kinds of things that's going to play into this. So changes in atmospheric pressure. All right, sea level, the pressure is going to be highest here. If you go below sea level, what happens? What happens as you go below sea level? What happens to the pressure? Gets higher. So people who scuba dive, then the pressure gets higher, right? Changes in resistance, diameter of the bronchioles, alveolar surface tension. If your alveolus collapse, and they can do that sometimes, if you are hospitalized for too long and you are not moving, you have a lung collapse. That's what they call that. Your lungs will, your little balloons will just slowly collapse because you're not moving around as much as you need to. If you have an infection, you might have a collapse. If you have a near drowning, if you aspirate a lot of water into your lungs, you lose surfactant. That whatever water or whatever you've inhaled into your lungs replaces that surfactant, and now all of those little balloons collapse. And then lung compliance. What did I say about lung compliance? What is important about lung compliance?
Because if it gets stiff, it doesn't stretch and expand.
And it doesn't allow for a good gas exchange. Emphysema, anybody heard of emphysema? So people, as they age, they can get emphysema. You're gonna notice these people because they're gonna be walking around carrying concentrators or oxygen concentrators. They're taking the oxygen that's in the air, concentrating it so they can breathe. It's only 21% in the air, but they need like probably 80 to 100%. So it concentrates what's in the air, and they looks like a little backpack, and they got tubing in their nose. They used to carry around gas tanks. Those are dangerous. They can explode sometimes. And then changes in intrapleural pressure. Some people will pop a spontaneous pneumothorax. Teenage males who go on great growth spurts really fast can do that. It's not a good feeling. We'll talk about all that. So the higher the altitude, the lower the atmospheric pressure. So I kind of already talked about that. If your pressure gradient drops, no matter how much volume you create in your pleural space, no matter how big of a breath you take, no matter how much your pressure drops in your chest, if the atmospheric pressure is so low outside, there's not enough of a gradient for air to rush in. So you actually have to draw air in. It makes it difficult to breathe at elevation. Make sense? So at some point, these folks are really sucking on air. You have to be in very good shape to do what they're doing. Diameters of the bronchi. So asthma is the one that comes up first here. So asthma can be genetic. It can be from smoke in the air. It can be from allergens in the air. It can be from poor nutrition. It can be from overweight. It can be from exercise. Some people will have exercise-induced asthma. And so they'll know to treat themselves with albuterol to prevent that from happening. So this is a normal bronchiole. You see that smooth muscle is all relaxed. This is a asthma-restricted bronchiole. All that smooth muscle is cranked down, and you even have some mucus in here. There's no way air is passing through here. And what happens with these kids, can even happen to adults, is so the air passes in, and then when you try to exhale it out, it comes out and have you ever taken a balloon and blown air into it and then released it, and just let a little bit out at a time, that kind of wheezy, that's kind of like what that sounds. Maybe that's a little bit more like Strider. So to fix that, by the way, that's a horrible feeling. Nothing will cause a human being more panic than inability to breathe or feel like they can't catch a breath. That will cause an extreme panic. That sets our brain on fire. So that look on her face is legit. there's rescue medications, and then we also have inhaled steroids. The inhaled steroids reduces inflammation and keeps that at bay. And then allergen processing and keeping the allergens out of not being around smokers is a really important thing. That's a big thing for parents who are smokers around their kids who are asthmatics. They think, if I smoke in the car with the windows rolled down, that's okay. It's not. They think, if I smoke outside but come back inside and all that smoke's still hanging on my clothes, that that's okay. It's not. You're still putting your kid at risk. So, premature infants, we talked about this, who are born without enough surfactant. If you don't have, what does surfactant do again? Somebody tell me what it does. What property does water have?
The tension, the
Stick?
tension.
Surface tension of water. Water has a surface tension that wants to hold water together. So air is humidified in those alveoli. So what does surfactant do?
Breaks the surface.
Breaks the surface tension to prevent alveolar collapse. That's correct. So premature infants aren't born with enough surfactant. So what happens to their alveolus? They all collapse. That's right. So do they have a hard time breathing? Yeah, they do. We actually have to intubate them pretty fast. Sometimes their lungs are so bad we have to do something called VV ECMO. We have to bypass their lungs altogether. Basically put them on a heart-lung bypass machine. That's not a good way to start out life. So that can definitely impact the resistance. And if your lungs are collapsed, what side of your heart do you think is struggling to be blood to? If your lungs are collapsed, the vascular bed is also struggling. So what side of the heart do you think is struggling to pump blood to that side?
Left.
No?
Left.
Who said right? Yes, it's the right side of the heart. The right side of the heart's pushing blood to the lungs, right? And so you've got lung collapse and you've got vascular issues in the lungs. That right heart's really going to struggle to put, and so the right heart could get into issues too. So everything's interconnected. I want you to think about all of that. So compliance, factors impacting lung compliance. So decreased lung compliance, chest wall deformity. Scoliosis is not something that a lot of people think about, especially if you don't have scoliosis. Back in our day, they used to make us in 4th grade all go to, you did this, yeah, me too. 4th, 5th grade, we had to go and we bent over in front of our nurse and they checked our spine and they moved us along. If we had an abnormal spine, they would send us to their doctors. And so they would do that prior to puberty. Because if you had some spinal curvature prior to puberty, once you hit puberty, it was going to get a lot worse. We knew that. Because that curvature was going to become more pronounced as you were having a growth spurt. So scoliosis, this is kyphosis, this is when it was up at the top. But if you had pronounced scoliosis, one side of your pleural space was going to be very much impinged upon, and that's going to impact your ability to take a deep breath. So they'll do spinal surgeries for folks like this. It's actually a very bloody, busy surgery. It can be very painful. So a chest wall deformity can absolutely impact the ability of your lungs to work, to fully expand and move and be able for you to take deep breaths. Clearly lung cancer. If you have cancer anywhere in your tissue that is cancer is not going to work the same way as tissue that doesn't have cancer. Cancer can clearly impact compliance. And lung fibrosis. Anybody seen those signs, those billboards for mesothelioma? Do y'all know what mesothelioma is? It's for people who's worked with asbestos. If you've been around an area with asbestos and you breathe asbestos in, it absolutely causes this lung fibrosis and will eventually cause cancer too. But lung fibrosis is basically like your lung is now basically concrete. It's solid, it's not going to move. And if you can't move, you're not gonna breathe. So that's what mesothelioma is. So asbestos is something that we learned a long time ago is bad, and it used to be in all of these old buildings. And so when they break these old buildings down, you have to have appropriate protection, or it gets in your lungs and it can cause a problem. But now lawyers are just waiting on something bad to happen to you. So when it does happen to you, they can help sue somebody. They can get paid while you're still suffering. That's a good life. Emphysema. So this is the other way. So this is too much lung compliance. So if you've taken something and stretched it out too far and it doesn't come back, that's also bad. If you've taken a rubber band and you've stretched it out too far, it won't snap and really snap somebody. They just kind of just shoots over. That's what emphysema is. So emphysema is for people who've had smokers will get emphysema quite a bit. And so they're still not going to have good gas exchange. They're still not going to have good oxygen exchange because they've overextended their alveoli. They're floppy. Their compliance has gone the other direction, and it's not, in that direction is not any good either. So increased intrapleural pressure. So what that means is, this is an actual collapsed lung. So this could be from an infection, this could be from a trauma. If you got hit, if you were in a car accident and one of your ribs got broke and your ribs pierced through the wall of your skin, and leaking air, your lung could collapse. If that spontaneous pneumothorax that I was talking about, so young men who are very tall, if they have and I've seen this happen where some teenage boys will go from 5'2" to 6 foot in the summertime. That amount of growth can sometimes cause their tissues, and that amount of growth sometimes it can hurt them a little bit, and they can pop a spontaneous pneumothorax. It's terrifying for them. They think they're dying because they can't breathe, and they'll come rushing into the emergency room. We'll do a chest X-ray, and then we'll pop a chest tube in just like this, and that chest tube will allow that lung to re-expand, and then we'll leave it in until it stops bubbling, and then we'll take it out, and hopefully it never happens again. But it's pretty terrifying for them. If it's an infection or blood or for some other reason, that chest tube might stay in for a lot longer. If it's an infection, what might come out of here is exudate or pus. And sometimes if it's in there really thick, we have to go in there and actually scrape that out. Yeah, it's pretty nasty. If it's from like a damage or like a surgery, we have to let that drain. Blood might come out, serous sanguineous stuff might have to come out. And it can be just air too. But do you think you're going to be able to use this lung to breathe if it's collapsed like that? No, you've got to fix that. Out in the field, if you're in a car accident and they think that you've got a collapsed lung, they'll actually take a large bore needle and they'll go between your second and third rib and they'll poke it in there from the outside and allow air out, and that can expand your lung in the field. They show everybody how to do that. So I want you to think about this question. There's one word that's immediately right and it's going to take away two of the answers right away.
Constriction.
So elasticity is definitely one of the right answers. And so I would make two of them go away right away. So elasticity is definitely in play.
D.
I would say alveolar surface tension too. So that is definitely going to impact compliance.
And that's related to the thing like flattening.
So if your alveolar surface, if you've collapsed, your lungs will not be compliant. The constriction of the smooth muscle I kind of think both of them are right. I actually argue with this question all the time. I actually think both answers would be right. I would never write that question. But forced inspiration. So forced inspiration is when now we're not just sitting around on the couch watching a strange show. Now we're doing something. We're running, we're working out, or we are in respiratory distress. Something is causing us to really need to take very large volume breaths and with significant amount of work and effort. So now we're going to use the same muscles that we use for relaxed inhalation, which are what?
The diaphragm and intercostal.
The exterior intercostals, that's right, and the diaphragm. So those are still in play. But now we're going to use the sternocleidomastoids. So we're going to use these ones in our neck to help pull up, right? Our pectoralis major and minor, but mostly our pectoralis major, and our serratus. These really cool ones that one day maybe I'll see again, but I doubt it. Like those are cool ones right there, right? So they're actively helping to pull your rib cage up while you're taking these big deep breaths. And you can see people when they're running and they're taking those big gigantic breaths. You can see how they're pulling their chest, their whole rib cage up as they're running to get as big a breath in as they can. And then they get to the finish line. What's the very first thing they do?
Stop and bend over. Yeah.
And you know what they just did?
Take a deep breath.
They cut off their breath. Your best thing to do is this. That keeps it open. But so this is forced inspiration. You are forcing great amounts of air into your airway as quickly as possible, and so that you're using a heck of a lot more muscles. I have seen babies doing this in respiratory distress. I'm going to show you a film of that here in a minute. Babies who get RSV, anybody heard of RSV? Respiratory syncytial viral. It used to be a virus. Used to be a virus that really was only a big problem for babies, but last year it became a big problem for adults too. It's killing elderly folks as well. So babies who are in respiratory distress, it looks like they're running a marathon and they're just laying there, and they have retractions. They'll retract underneath their rib cage, they'll retract in their chest, they'll retract because they're trying so hard to breathe. It's really incredibly painful to watch. Forced expiration. So forced inspiration is pulling up from above. You're pulling the rib cage up. Forced expiration is you're pushing it from below and out. So the same muscles that you use to stool and the same muscles you use to vomit are basically the same muscles that you're going to use to blow that air out. So your intercostal and your abdominal muscles are going to be very much in play for breathing out. And when you take those big deep breaths, when you blow out, you can tell that you're using your abdominal muscles for that. If you ever do any kind of like breathing exercises, you'll feel that you're really using your abdominal muscles for that. Your rectus abdominis and other abdominal muscles. So, but it makes sense if you think about it. Forced inspiration, you're pulling from above. Forced expiration, you're pushing from below. Forced expiration is an active process. You're using muscles to actively exhale. Passive exhalation, exhalation that you're just doing passively does not require effort. Yeah.
Down.
Yeah. Everybody get that?
Mhm.
This is one of my favorite graphs. So, before I do this, I'm going to show you so you see how he's collapsing? under here. And his neck, you see how his nose is flaring? And that's actually not even that bad. That baby's much worse. See how that baby's really tugging? So that baby's really working hard to breathe. I would actually take the pacifier out of the baby's mouth. That baby's really working hard to breathe. So babies' nares are pretty occluded. Babies are actually obligate mouth breathers. So that they're actually leaving that pacifier in their mouth actually makes me a little bit crazy. But these babies, when they're laying there and they're working now, that you can see, just looking at that, you can tell that they are working hard to breathe, and they are using all of those muscles that we were just talking about. They're using all of those muscles. They are pulling in air as hard as they can. There's something wrong with their lungs, and eventually, if you don't do something to intervene, they will tire out, and then you've got problems. Babies very rarely have cardiac arrest for cardiac reasons. It's almost always respiratory reasons. I mean, I work in cardiac, so our kids will have cardiac arrest for cardiac reasons, but majority of babies, they can go into cardiac arrest for respiratory reasons, and it's usually like RSV or something like that. But that's what I mean. You can tell they are working hard to breathe, and that is respiratory distress. I've seen that with big people too. And if you were in a COVID ward, before people were getting to the point of needing intubated, with the tube down their throat, that's what they would have looked like. They're laying there and they are huffing and puffing. I'll talk to people, I'll call people like, I'm short of breath, but they're talking to me in complete sentences. People who are truly short of breath, they're going to talk and they're going to take breaks after every couple of words. That's true short of breath. You can't catch your breath, and you're terrified. I hear people call me like, I'm short of breath. Can you give me a hamburger? Like, that's not short of breath. You know what I'm saying? Like, that's not short of breath. So, this graph here tells us a lot. This graph changes based on your sex, meaning your gender, and your age, and how good a shape you're in. And do you have any comorbidities? Are you a smoker? Or you're not a smoker? Do you work out? Do you take care of yourself? Are you obese? So this graph will tell you a lot. So this line right here, tidal volume, this is what y'all are all doing right now. This is the inhalation and exhalation you're doing right now in easy breathing. That's tidal volume. It's about 500 mLs. And we measure this. If you went into a body box, they put a clip on your nose because you don't want to lose air volume. They would measure you just breathing normal. And that breathing normal would be your tidal volume. Then they would ask you to take the biggest inhale you could. That biggest inhale you could is your inspiratory reserve volume. Now, if you are a swimmer, or you're one of those free divers that goes down like a quarter mile without anything on, your inspiratory reserve volume might go off of this chart. But if you're a smoker who's obese, your inspiratory reserve volume might just go right here. And so if your inspiratory reserve volume is truncated like that and you get sick, do you think that makes a difference? Huge. That's when we say you have no reserve. But if you take it off the charts, you get a little pneumonia, you've probably got enough lung volume, you're probably going to be okay. You'll probably survive it. So this is your inspiratory reserve volume. So it's how much you are able to expand your lungs above and beyond what you're normally doing at a normal rate. And then you blow out. Expiratory reserve volume. You blow out all that you can. Now this is interesting. You're able to breathe in a heck of a lot more able to blow out. Why?
Because you use the air.
You don't want to empty your lungs, right? Would you ever want to empty your lungs completely?
No.
Why? What would happen in your lungs?
They collapse.
They start collapsing. All those little balloons would start collapsing. All those little alveoli would go, oh, I can fix that. So that whole together from expiratory reserve volume to inspiratory reserve volume is called vital capacity. That's how well your lungs are working. What you have left, what you never empty out of your lungs is called residual volume. What never empties out of your lung. Now, as you age, that might change. As you age, everything always gets a little stiffer, gets a little fibrotic. You are exposed to things as you go through life. Mowing the lawn. You might not think that that's a big deal, mowing the lawn. But all that grass and stuff that you get in your lungs doesn't really go anywhere. Your body can't break that down. It gets trapped in your lungs. Going on campfires. Seems like a really benign thing to do. If you do that all your life, you probably are damaging your lungs a little bit.
Painting.
Huh?
Painting.
Painting. Right, all these things that you don't think about, but as you age, it catches up with you. So now you're 78, 80 years old, it's harder to breathe. And you'll see that. The old folks, they just slow down a little bit, and part of that's breathing. They get short of breath going to the grocery store. They get short of breath going to just get their mail, right? They just get a little short of breath. They get tired out, and they're ready for a nap in the middle of the day. Yeah.
Does skydiving affect your reserve?
Skydiving would do what?
Would it affect your reserve?
No, that's an interesting question. No. I mean, it affects your scream. If you have good reserves, you'll be able to scream longer. On the way down. So, all of that all together is your total lung capacity. Without breathing, there is no life. That's it. Without breathing, there is no life. So taking care of your lungs is a really big deal. These kids who are vaping, they think it's no big deal. I'm going to show you real quick what vaping does to your lungs. That's a vaping chest x-ray. So I'll show you a normal chest x-ray because that's holes in your lungs.
Mm.
That burns your lung tissue. That's putting like holes in your lungs. None of that's normal. That's called blebs. Is it going to happen to you? I mean, there's not 100%. It's not 100%, but it could. Like that's from it. Like, So this is the scarring of lungs from the elderly. So that's what I said. Like, as you age, you can get some scarring. So that's some scarring from what happens. And so if it scars, it's going to be stiff. It's just going to be stiff. Let me show you a normal x-ray. No. What are you doing? Bing. Thank you. Images. This is a beautiful normal chest x-ray.
You said we have a problem.
Why? Okay. Can y'all see that well enough up there? All right, so you can see the heart. Let me move the little hand off there, maybe that'll help too. And you can see the heart. You can see the lungs. You can see some vascularization. You can actually see the trachea and some bronchi on this x-ray. I'll show you again when we get to the lab. But the heart's normal size. You can actually see the diaphragm here. They ask you to hold your breath. You can see the diaphragm here. It's a very pretty x-ray. Nothing going on with that. If it's see-through, you know it's air. But you see some normal vascularization there. That's a normal chest x-ray. The other ones, I'll show you more when we get to lab that are worse. But we do stuff like this for people who have obstructive or restrictive airways. So if you've got some sort of, like that fibrotic area in that elderly x-ray, they're not gonna have the same inspiratory reserve volume. A person with asthma is not gonna have the same expiratory reserve volume. It's gonna be blunted because they can't blow it out as well because of that restriction of their bronchioles, right? Same thing, respiratory, this is the same thing, just saying the whole thing over again. But you're gonna need to know these, and we'll talk about them in lab too. Here it is in written form and with some milliliters ascribed to it. Now this is just typical in general. This would change, again, like an 18-year-old boy is gonna have much higher inspiratory reserve volumes than an 80-year-old feeble old lady, right? So take that into consideration. So tidal volume is what you're doing at rest. Inspiratory reserve volume is what you're able to inhale above and beyond tidal volume. Expiratory reserve volume, maximum that you're able to exhale above tidal. And again, that's going to be much smaller than your IRV. Your ERV is going to be smaller than your IRV. Residual volume is what is always going to be in your lungs. You should never be able to get rid of that. And dead space, we didn't talk about that. Dead space is your conducting zone, right? Conducting zone goes from what?
Residual volume and total lung.
Goes from where to where?
Oh,
From your nose
to
to
your,
your,
Starts with a C, doesn't it?
It does, starts with a T.
Oh, I said C.
No, starts with a T.
trachea?
No.
Yeah.
It's like you're going to an airport.
terminal.
Mm-hmm. Terminal bronchiole. Your dead space. Terminal, like from your nares to your terminal bronchiole is dead space. You're not doing any gas exchange there, right? That's your anatomical dead space. That is air that you have moved, that you have brought into your body, that is, you're just conducting. There's nothing you can do about that. That is anatomical dead space. About 115 mLs. You can have physiological dead space. Physiological dead space can be from disease. If you have a collapsed lung, if you have pneumonia, if you have that one chest x-ray there with all those bloods in it because you've been vaping, now you've created physiological dead space. That is space, that is lung tissue you are not using to do gas exchange. Now you've created more dead space. Do you think that impacts all these other volumes?
Yes.
It absolutely does. This is a great question.
Respiratory? Right? Actually, all of them.
That's right, all of the above. All of the above.
Breathe.
People who play reed instruments have great lung volumes. Because they have to take those big deep breaths, they gotta play, their expiratory reserve volume is really good, they have to play them for long periods of time. They have to know when to break to take a breath so they can keep playing.
Fingers.
Yeah, their lung volumes are usually pretty good. Do you think those folks are smokers?
No.
No, they're not good smokers.
Singers also.
Huh?
Singers.
Singers too. Even though some of them are smokers. Like the guy, lead singer from AC/DC would smoke a pack of,
Amy Winehouse.
she was a lot of things. She was also a great singer who is too bad.
So they tried to get her to go to rehab, but she said,
She said no, no.
Whitney Houston as well. Whitney Houston as well.
It's funny she wrote a song
Whitney
about it.
Houston,
Oh yeah, when you
one of the
oh
best.
yeah.
Who?
Whitney Houston.
Yeah,
Janis Joplin.
Whitney was one of the best. She should never marry that man.
True.
She did that on her own though. They blame Bobby, but she thought it was straight.
Oh,
I have a theory why.
Oh.
You tell.
You tell.
Yes, I heard that.
I don't think I'm wrong.
Well, it's come out now.
I think she did it because her family would have been very mad at her. And that's why she stayed high the whole time. It's too bad. I think I'd rather my kid be happy and alive personally.
Yeah.
that's recently come out.
Okay, so that's right, all of the above. Okay, so here's what I was talking about, anatomical dead space. So this is dead space that is you can't get around it. It's from your nose to your that terminal bronchus. It's where no gas exchange happens. You need to know this. This is an important detail. So, you can't fix it. You can change it. Anybody ever gone snorkeling? When you go snorkeling, when you first go snorkeling, is it a little bit hard to breathe initially until you get used to it? It does, because you've just increased your anatomical dead space. You've just increased your trachea by what, 12 inches, right? You're now having to pull harder to get more air down to the area where you're actually exchanging gas until you kind of get your body used to it and you relax. It actually causes a little bit of panic at first, doesn't it? For people who have never ever snorkeled, you first start doing it and you're like, oh crap, that's harder, and it causes a little bit of a panic. Air hunger will cause immediate panic. Okay, physiological dead space. This is dead space. Now this can happen for a couple of reasons. It can be a physiological dead space because you have a damage in your tissue, in your lung tissue, or you can have a blood clot. So it's the inability to have a gas exchange. So it could be because you can't get blood into the lungs. So it could be a clot. Or it's because you have damaged lung tissue. Pneumonia just means that you have inflammation in your alveoli. So you could have inflammation in your alveoli for any number of reasons. It could be a viral process, it could be a bacterial process. It's some sort of disease state. So we call that a VQ mismatch. And so you've got diseased lung, you've got plenty of blood supply there, but because what used to be this single cell beautiful little thing here that was going to be easy to have gas exchange, suddenly now is thickened with inflammation. Is that going to have gas exchange? No, it's not. And so now you have all these alveoli that's thickened and fighting infection, probably full of fluid. So no gas exchange, and so all that blood supply that's around it. And what type of cells are going to be involved in the gas exchange? Type 1, type 2, or
Macro.
Type 1, that's right. It's type 1. Macrophages does what?
Cell
Macrophages are
eating.
doing what?
Cell eating.
They're fighting whatever's that's causing the problem, right? So what we have here, what we're having here is that's the VQ mismatch. You got plenty of blood coming to here, but you're not having any gas exchange because there's a disease state. You could have perfectly normal alveoli, but you've thrown a clot. Our lungs are made to actually take in a certain amount of clots, small clots. A big clot, that's going to cause a lot more problems. I told you about the girl on the plane who had through a pulmonary emboli and died, and the plane chose wrong. So that cut off far too much. The clot was too big, cut off too much blood supply to too much of the lung. So she was breathing fine. She had plenty of oxygen down there, but there was no blood supply, so she had no gas exchange. If she had no gas exchange, she wasn't getting oxygenated blood back to her heart. And then eventually, she wasn't getting oxygenated blood back to her coronaries, and her heart didn't like it. She went into full cardiac arrest, right?
Surface tension.
Go ahead on, Wolf. You didn't even let everybody else read it.
I mean, I have the paper right in front of me, so.
Say it again for everybody else.
Surface tension.
The surface tension. Water has a great affinity for itself. It likes to look at itself in the mirror. And that surfactant breaks that surface tension, breaks it apart. Did you say like you?
Do I have surface?
Right. Okay, so this is another law you need to know, Dalton's law. So we had Boyle's law, which was a pressure-related law. Now we have Dalton's law. Dalton's law is, we're going to talk about the partial pressures of oxygen, the partial pressures of nitrogen. This is the partial pressure, and all makes up to 100% of all the air that we breathe. This is just talking about partial pressures. I don't want you to get too wrapped up or confused about this. This is just, I'm gonna tell you, they were smarter than us, those folks back then, that they were figuring this stuff out without they didn't have computers. They didn't have half the things that we have at our disposal. They just had the brain and to think through stuff. I think they were pretty brilliant back then. So this is partial pressure. So again, most of what we are breathing is inert nitrogen. Majority of what we are breathing in the air right now is inert nitrogen. We're breathing about 21% oxygen, and then we are breathing carbon dioxide, right? We're exhaling that. What really appreciates the carbon dioxide?
The flowers.
The flowers and the trees, and they convert that to what?
Oxygen.
Back to oxygen for us.
It's inert.
Inert means
Oh,
inert.
inert.
Yeah. Wasn't name calling anybody.
It's inert nitrogen. I'm like,
Right. Then we have a little water vapor. We also call water vapor what? What's another name for water vapor?
Humidity.
Humidity. Correct.
Oh yeah, I feel like if it's Florida, nitrogen and water vapors.
Say it again.
I feel like it's Florida. If it's Florida, nitrogen and water vapor are exchanged in the graph.
Yeah. Okay. So gas exchange is done by simple diffusion from what to what? What are we doing? What is it always from?
From high pressure to low pressure.
So high to low. This is always the thing. Everything in almost in nature wants to balance out, right? So it wants to go from a high level to a low level. It's a gradient, right? So in your blood, in your alveol, but you gotta be careful about this, right? So in your venule, is your venule oxygenated or deoxygenated?
Oxygenated.
Right. So in your venule, so right now, but this is your arterial. So your arterial, okay, your pulmonary arterial, is it oxygen poor or oxygen rich? Poor. So, and now in the alveoli, is it oxygen poor or oxygen rich?
Right.
So the partial pressure of oxygen in the alveoli is going to be greater than in the arterial, in that capillary. So the gradient is going to go downhill and want to go into the capillary. Make sense? Carbon dioxide is going to go exactly the opposite way. Because the carbon dioxide's been hitching a ride on that blood, now it's going to go, oh, the gradient's the other way. There's less carbon dioxide here in the alveoli than there is here. There's more. I'm going to go this other way. And then you exhale out the carbon dioxide and you continue to breathe in oxygen. And in those capillary beds, that's when everything happens, right? And you exchange. So it goes from higher partial pressures to lower partial pressures. And it's not necessarily a balance out. You don't go 50-50. That's not what happens. You fill up and you move on, okay? This is a really important point. I want y'all all to understand this. External respiration happens in the lungs. Internal respiration happens in your tissues. That can be very confusing. External respiration happens in your lungs. Internal respiration is happening in your tissues. So in your tissues, in your capillary beds, in all of those small spaces all around your body, internal respiration is happening. So in internal respiration, what's occurring?
Internal.
Gas exchange.
Oxygen. Right, so tell me the process. What's going where and what's coming out?
Oxygen.
Oxygen's going from
the vessels to the tissue.
Correct, and what's coming back across?
Carbon dioxide.
And
Waste.
waste, right? So it's not just oxygen, it's also hormones, and it's also glucose, and it's also proteins, and it's just it's a conveyor belt, right? Of like all the things that those cells need, and then what's coming back across is CO2. But we care about the gas stuff, so we're going to stick with the gas. So that's what's happening, so that's an internal respiration, and then it comes back up through the body, through all those routes that we've already gone over. Comes back to the heart, gets back into the lungs, and now we're going to do external respiration in the lungs. Because now it's going to go out, it's going to eventually end up outside of the body. That CO2 you're going to exhale. So that's what respiration is. So ventilation is how well you're breathing. Respiration is how well you're breathing off CO2. So external respiration, again, is happening in the respiratory capillary membranes with those type 1 alveoli cells. And as you can see, you have the PO2 of 40 and your PCO2. So that basically means partial pressure of oxygen and the partial pressure of CO2. In the alveolus, the partial pressure of oxygen is 100 and the partial pressure of CO2 is 40. As we're moving along, the oxygen just pours into that vascular tract. Now the partial pressure of oxygen is 100. The partial pressure of CO2, that little detail moves over. So now the partial pressure of CO2 is now 40 and you're heading back around. But they just basically changed. So you just had this moment of change. Your partial pressure of oxygen does significantly increase. Your partial pressure of CO2 didn't really change that much, but it's enough for you to blow out that CO2.
Wait. But.
So you dropped off 5 millimeters of mercury of CO2.
Yeah, but doesn't the law of like David says that it should be equal like on both sides or on the.
They are equal here.
No, I mean like, cause the pressure on the venule side is way lower than on the other way around, on the arterial to the venule.
They are equal here. So, and that's what it is just partial pressures. And don't get partial pressures confused with how many of the hemoglobin, because that's a different thing, okay? This is partial pressures. So, air that enters the lung from the atmosphere has a blank partial pressure than the air in the alveoli in the lungs. So it's moving, right? You gotta think about if it's going to move, if it's gonna move from higher to lower,
That means that pressure outside has to be.
yeah,
higher.
it has to be what?
Higher.
There you go. I don't really like that question very much. Anyway, so now we're in internal respiration. So you can see that some of the oxygen on the way through the tissues has dropped off. It's not 100% anymore, right? But the PCO2 is still 40. But out here, we've used all of that oxygen in our tissues. We've used that oxygen for what? What do we use oxygen for?
You got energy?
Do I what?
You got energy?
Cellular respiration. That's right, ATP. That's what we use oxygen for. It's our last electron receptor for our ATP production. That's it. That's what we use oxygen for. So we've used all that oxygen for cellular respiration. Now we need to do some exchange down here. And the byproduct of that is we create CO2. So CO2 has been created. So now we're gonna do the exact opposite down here. So, and you can see, lo and behold, the same process happens. So now, what's in the tissue shows up here in the venous system as it's coming back. And the arterial side has dumped all of that in there. But we've exchanged it, and now it's coming back up to the heart. So that is internal respiration. But you can see how oxygen is going to easily diffuse into those tissues because of that very significant gradient of the partial pressures. Okay, so hemoglobin and oxygen will become oxyhemoglobin. So where would oxygen and hemoglobin first form? In the lungs. That's right. So that's external. So that's where oxygen and that's where they're going to come together. They're going to come apart where?
The tissue.
In the tissue, so the oxygen can get out there and go to the cells. That's correct. This is another place where we talk about external and internal respiration. Same slide, kind of going over the same thing, but it's really important to understand the difference between the two. Read these questions carefully. Hey, first of all, read this carefully. Does not accurately describe internal respiration.
B.
What'd you say?
B.
B?
Yeah, because that's about the alveoli and internal respiration is on the tissue.
Pressure. There's one word in that makes it incorrect. That's true. Anybody else can tell me what that one word is that makes that wrong?
I think D.
Alveoli.
Correct. This is why this is a good like test question. Internal respiration occurs where?
Tissue.
In the tissues. So that you can read all of that other stuff if you want, but alveoli immediately makes that wrong. Because that is what kind of respiration?
External respiration.
Yeah, there you go.
What's
Gas
the right- wait, what's the right answer?
B.
B. Okay. Gas transport. Now, we've kind of talked about this, but we're going to get into a little bit more detail, a little bit more crux of the matter. So, red blood cells have a great affinity for hemoglobin. So when that partial pressure of oxygen gets pulled over into the capillaries in the lungs, as soon as they pull over and those red blood cells get that hemoglobin, that oxygen gets attached to the hemoglobin, there's 4 of them, right? So 4 oxygen get attached to each hemoglobin. What is this right here? What is this? Iron. Once that oxygen attaches to that iron, these proteins actually change form and kind of lock the oxygen in place and hold it until it's time to let it go. So every hemoglobin can carry 4 molecules of oxygen. Now we're on the move. And every red blood cell has millions of hemoglobin, so you can have billions of oxygen on them. Once that happens, once oxygen and hemoglobin combine, it's called oxyhemoglobin. That's what we've now called that. Now we have oxyhemoglobin. So it's actually not as easy as you would think for that oxygen to disassociate from that hemoglobin to get in the tissues. There are some things that make that oxygen want to jump off the hemoglobin and get in the tissues, and then there are things that make the oxygen kind of want to stay on the hemoglobin and not get into the tissues. Clearly, the oxygen not leaving and getting out into the tissues is bad, right? What do you think that causes those tissues to go into? You shock, like they go into shock. Without oxygen, they start going into cellular death, right? They can't make ATP, they can't go into their cellular processes, they start dying. So you really want that oxygen to be able to come off of that hemoglobin and go into the tissues when necessary. So, this is called a oxygen hemoglobin dissociation curve. I don't want you to get too put out about this thing. I'm going to explain. So, at a certain point, for everybody, oxygen's going to just appropriately want to leave the hemoglobin. It has to be at a certain point. It's under the partial pressure. It does this under partial pressure. So we already seen this at 40 and at 100. 40 is out in the tissues, 100 is in the lungs. And then you have percentage of how the hemoglobin is, how saturated the hemoglobin is. And I think y'all remember me telling you from the very beginning, not all of the hemoglobin loses their oxygen all the way around. We have kind of a reserve of that. And so that's why you see it's only about 70%. This is the volume of O2 that's unloaded into the tissues. It's not much, but after a certain percentage, it drops pretty considerably. So if you did not have your, let me explain it to you this way. If at this point you did not reload the oxygen, if you didn't have a cardiac cycle, you would drop off pretty fast. You would use that oxygen out in those extremities pretty fast. But if you have a cardiac cycle, you'll be able to continue and reload. Okay. So, there are things that make the oxygen want to just leap off the hemoglobin. Things like fever, things that increase your cardiac output, exercise. So, decreased, what does a decreased H plus mean to anybody?
Concentration of hydrogen.
What?
The decrease in the concentration.
So let's talk about right shift first. I'm so sorry. So, increased temp. Right shift means reduced affinity. That means the oxygen wants to just jump off of the hemoglobin. So increased temp. So you can get that by working out. You can get that by having a fever. You can get that by any number of ways. We're going to skip this. Don't worry about that. Increased. What does increased H mean to you?
That'll be like more acidic.
You're more acidotic.
Yeah.
Right, so that's right. So your tissues are requiring more oxygen because you're more acidotic. So all of that fight or flight thing is coming into play. You're more acidotic, your chemoreceptors are kicking in, your heart rate's squeezing harder, your lungs are breathing harder. You want more oxygen in your tissues, so you have a reduced affinity to hold, your hemoglobin's kicking off oxygen like it's its job. And you're breathing more, you're kicking up, your body's metabolic processes are all kicking up. That's a right shift. A left shift is doing the exact opposite. So if you're cold, people who are super cold will hold on to their hemoglobin. If they're very alkalotic, they're going to hold on to their hemoglobin. What does CO mean?
Carbon monoxide.
Carbon monoxide. This is why carbon monoxide poisoning is so dangerous. Carbon monoxide is the only thing that has a stronger affinity. Our hemoglobin has a stronger affinity for carbon monoxide than it does for oxygen. And once carbon monoxide gets on our hemoglobin, it's very hard to get it off. The only thing that actually can get it off is high pressure oxygen. You have to go to a hyperbaric chamber and force the carbon monoxide off. What do we have in our homes that has a lot of carbon monoxide in it?
Car.
Huh?
Car.
That's how some people kill themselves. And you just fall asleep. You get a little bit of headache and fall asleep, and that's it. People who use gas appliances. So if you have gas appliances, they tell you to immediately go get a carbon monoxide detector. What usually happens in the wintertime is people use those space heaters. And if it's a space heater that it produces carbon monoxide and they don't get it tested or it's old, Definitely seen people die, using carbon monoxide. And it is subtle. One of the worst stories I've ever heard was, like, the dogs knew something was wrong and they were trying to wake up the owners to get them out of the house, and the dogs died. All their people in the house died. The dogs died trying to get people, they were pulling them, literally pulling the people to try to get them out of the house. Because they knew that they were all, because carbon monoxide is odorless. You don't know what's happening. You'll have a little bit of a headache, but when you're asphyxiating from a carbon monoxide poisoning, there's no real tell to it. You just get tired. Because you're not getting enough oxygen to your brain, and you go night-night. So, shift to the left, oxygen doesn't want to come off your hemoglobin. Shift to the right, oxygen freely wants to come off your hemoglobin. Then you just have your normal oxygen dissociation rate. So, let's stop here. Carbon dioxide transport, we'll leave that for next Tuesday. If you haven't read about the oxygen dissociation curve, you haven't read the respiratory stuff, I highly recommend it. It can be confusing. I know a whole lot of people that I work with haven't really understood it. But it's important to understand.